Thank you, Oliver, for introducing me and even for pronouncing my name correctly. That's great. It's a pleasure to be contributing to this meeting this morning. Our company is founded on the premise that the thymus is a key target for aging intervention. As you all know, the thymus is this gland in your chest cavity that manufactures the T cells that you need to defend yourself against cancer and infectious diseases. The problem with the thymus is that the functional mass of the thymus declines rapidly with age. So by the time you're about 50, you have lost about 90% of the functional mass of your thymus compared to where it was when you were in your early 20s. And that eventually leads to a deficiency in the production of T cells. And as T cell populations decline, the ability of your immune system to recognize foreign antigens declines by about 98% between the ages of 60 and 80. And that is associated with functional declines in the ability of the immune system to perform. This just shows the change in ability to respond to subcutaneous antigens as you go from being a 20-year-old to being a 60-year-old. There's about a 60% decline in really good immune responses and about a 40% increase over the youthful rate of having almost no immune system function, which is about 0% in youth. You're about 40% likely to have no immune system function to speak of over the age of 60, according to this result. And unfortunately, that also leads to an increased probability of death. So independently of other signs of morbidity or or health, the number of people that are dead in 2 years can be predicted by your immune quality score, and of course goes up as you have a poor immune quality. As Brian Kennedy pointed out, this leads to the practical result that people tend to die of flu after they're 60. They tend to die of COVID after they're 60. And you tend to die of cancer after the age of 60. This is prostate cancer. And I compiled statistics from the CDC about the percentage of all deaths due to cancer and infectious diseases, which may relate to decline of immune system function with age. And when you're 20, maybe you have a 5% chance of dying from one of these conditions if you die. But if you die after the age of 50, you have more like a 35% chance of dying from something related to immune system function, and that probably underestimates the effect of the immune system function on morbidity, mortality, in my opinion. So if we don't reverse thymic aging, all other interventions will ultimately be futile because we'll die of immunosenescence. So that's the reason we're focusing in this area. So we started the TRIIM trial at Stanford University and ran it from 2015 to 2017. And most of you know about this. We're not going to spend a lot of time on this, but the objective was to regrow the thymus using a combination of growth hormone, DHEA, and metformin. This was done on 9 healthy men who were treated 4 times a week in order to stimulate regrowth of the thymus. And we published the results in Aging Cell, and it's available online. So some of the results that we obtained were, first of all, with respect to the goal of thymus regeneration specifically, we obtained MRI evidence in which we were using MRI techniques to image fat versus water, water being a marker of non-adipose thymic mass or functional thymic mass. And you can see from the imagery and from the analysis of the imagery that we did, there was very strong evidence that we were able to replace thymic fat with thymic functional mass as a result of our treatment. And then in terms of the functional consequences of that regeneration of the thymus, we increased naive T cells, newly produced T cells from the thymus, and we reduced senescent PD-1 positive CD8 T cells, which is in keeping with what we had hoped to see. We also saw a reduction in inflammation, at least based on a reduction in CRP, and we also saw a very happy reduction in prostate cancer risk factors. Some of the things we did not expect to see were hair darkening in 3 out of the 9 volunteers in the study. We were only able to document it in this one case, but 2 other people reported this to us. And an apparent improvement in kidney function, at least the kidney filtration rate, estimated GFR, going up statistically significantly by 9 and 12 months, and then continuing on, apparently perhaps after the treatment ended at 365 days. And the other results of the trial, which caught a lot of attention, happened to be aging clock results. Steve Horvath did these results for us, so I believe them. He started off looking at the DNA methylation Horvath clock, and to his surprise, it seemed to indicate that aging was going in reverse. And so he double-checked this using the Levine clock, the Hannum clock, and the Grimm age clock, and they all showed basically the same trends, although the details were slightly different. If you look at the average of all of these clocks, you see after about 9 months, we went back about a year, and after 12 months, we went back about 2.5 years. And that effect persisted somewhat even at 18 months after, so 6 months after the end of the treatment. And so to put that in context, with normal aging, you get a year biologically older. If you could achieve something called longevity escape velocity, you'd maintain your biological age for that 1 year of time. And we actually reversed the aging that took place during the trial, and then went back another 1.5 years. So this was something novel and something interesting and intriguing, which of course we'd like to know more about. The other feature of the alleged aging reversal, or epigenetic aging reversal more properly, is that it seemed to accelerate over time. So for the first months of the trial, we went back in time by about 1.5 years for every year of treatment. And near the end, the last 3 months of the trial, we were going back the rate of about 6 years for every year of treatment. Now, since the trial was published, Steve went back again and looked at this other aging clock that Morgan Levine came up with, which I call the plasma phenoage clock. It's different from all these other clocks. The other clocks are all based on DNA methylation changes, which require us to make measurements on frozen tissues, which means that we can't make measurements during the course of the trial. But the Levine clock is based on a series of simple blood tests, and it also showed trends that were broadly very similar to what we saw with the epigenetic aging clocks. It also reached statistical significance after 12 months. And one of the things that I haven't mentioned before is that we've presented our mean results, but of course some people do better than the mean. So the best epigenetic aging reversals were up to 4 to 10 years, and the best plasma phenoage reversals were up to 9 to 11 years. So there are a number of caveats with this original study. One of them is that there are no untreated controls. Another is that there are no placebo-treated controls. And I just want to say a word about placebo-treated controls. It's really impossible for us to do placebo-treated controls. And the reason for that is the way we do the injection. So one of the major components of the treatment is growth hormone, human growth hormone. It comes delivered in these ampules that are designed to go into these special injector devices, which are quite wonderful for reducing pain upon injections. We never had anybody who could not inject themselves due to pain, but the manufacturer does not manufacture placebo versions of these cartridges. So anyone in the trial who was forced to inject themselves using an ordinary syringe with some kind of sugar water solution would know that they're not getting the real growth hormone. So it's really impossible to design placebo control at the moment, although we are going to be changing that hopefully in the future. 2 other omissions from the original trial were that we did not have any women, and that of course we were looking at a limited range of volunteer ages. So the objectives of the TRIIM-X trial, the extension of the TRIIM trial, are to attempt to replicate the key TRIIM results. using a telemedicine approach. We were forced to do this because between TRIIM and TRIIM-X, COVID hit and people were no longer free to travel and all kinds of other restrictions. So we created telemedicine apparatus to enable anyone in the United States to participate from afar. That's still in existence and very useful, so we continue to use that. We move our base of operations from Stanford to Southern California, mostly for convenience and also for cost. And in TRIIM-X, we also are including controls. There's going to be a no treatment group. Currently, we only have one person in that group, and there's going to be a treatment with DHEA and metformin only group. And currently, we only have one person in that group as well. So it's a little early to share results, so that they're interesting even now. But we still have no placebo controls for the time being. So we're hoping the results will be sufficiently interesting to justify creating placebo controls down the line. We will, of course, expand the age range. We're already doing that, and also the health range, because we want our treatment to be applicable not just to healthy people, but to a broad swath of the population. And in TRIIM-X, we're expanding the treatment time from 12 months to up to 15 to 18 months to see if aging acceleration will continue longer than 12 months. We're definitely including women. Because of the inclusion of the women, we've begun monitoring and correcting estrogen changes, because estrogen is a very thymic involuting molecule. And we haven't seen too many issues in that regard yet, but we're conscious of that now, whereas we were not paying attention to that in TRIIM. And then we're including functional changes such as cardiopulmonary exercise testing for aerobic capacity and strength, also DEXA scanning of body composition, frailty scoring, neurocognitive scoring, and we will eventually do T-cell proliferation testing, which has been linked to probability of survival in humans in the past. We're also making thymus imaging optional in TRIIM-X, and we've begun doing that by CT. We've completed enrollment for the first part of TRIIM-X, and when we resume enrollment, we'll probably go back to MRI, but that's optional for the time being. So those are the objectives, but actually achieving the objectives is a little bit complicated. It's certainly complicated to have the results to present to you today, because many of them require the study to be completed, and it's not completed yet. So for example, thymus scans and CPET data, et cetera, will mostly be compiled at the end of the study, and all of those particular assays are optional, and so not everybody has contributed data along those lines, but I will show you some data that we've collected. The immunological assays, of course, are core to the ultimate objectives of the study, and those can only be done on frozen samples, which are analyzed after the study is over, so I don't have any of those results for you today. The epigenetic assays, very similarly, are to be done on frozen samples, so we don't have those results for you today, although we do have plasma phenoage results for you, because those can be measured in real time. But I'm going to be providing a little bit more perspective on what those results mean in terms of the other clocks, which are based on epigenetics. There are several results that are based on simple blood tests that we can also track in real time, so I will present some of those for you. And then the other thing that's a bit new is that we do have subjective and some objective volunteer feedback that we've obtained, which is also valuable for assessing the results of the trial, and I'll discuss some of that with you as well. Other complications are that some volunteers got COVID, either early or late, and all got COVID vaccination, which may affect some of the results. And some volunteers had to pause their treatment for side effect resolution or various kinds of injuries. And one guy actually had his hip replaced partway through the trial, so he took a time out for that. So these things make it a little bit harder to make comparisons as well, but we'll do our best. So first point, demographics. How does TRIIM population differ from the TRIIM-X population? We have a total of 9 men in TRIIM, 20 men in TRIIM-X, and 6 women volunteers in TRIIM-X. Of the 20 men volunteers, 2 of them are controls. of the kind we described before. The age ranges are higher in the TRIIM-X trial, but the men the same age. Interestingly, the plasma phenoage baseline is similar in TRIIM and in TRIIM-X, and also between the TRIIM-X men and women. But the baseline difference between plasma phenoage and chronological age was much, much greater in both the TRIIM-X men and the TRIIM-X women. So in terms of aging, the TRIIM-X people were much, much healthier going into this treatment than the people were in the TRIIM study, which may have some effect on the outcome. This is how we're doing in terms of enrollment so far. Total of 26 people in the trial, 20 men and 6 women, as I pointed out before, and 2 controls. We stopped enrollment for a while so that we could sort of wrap up this phase of the studies, improvements, but we still have about 10 people enrolled in the trial. That will probably go to 0 in the next 2 to 3 months or so. Just in terms of length of treatment that have been selected by the volunteers and ratified by us, about half of the women have elected to continue beyond 12 months of treatment, and the majority of the men have continued on for 18 months or will continue on for 18 months of treatment. So one way of comparing TRIIM and TRIIM-X in terms of seeing if we can reproduce the results of TRIIM is to look at the side effects, at least the subjective side effects. So TRIIM, 3 out of the 9 guys had symptoms related to carpal tunnel syndrome or things like it, or arthralgias, which were all successfully controlled by dose moderation. In TRIIM-X, 1/6 of the women had an issue. In this case, that was caused by a prior accident, which was exacerbated by the effects of growth hormone on tendons and so forth. That's been surgically corrected since then, so that's problem was solved. And just as in TRIIM, about 1/3 of the men were affected by this symptom, about 1/3 of the men were affected by it in TRIIM-X. In one case, it was actually limiting to the point where we actually let somebody end the trial because of it. But in most cases, it's not that bad and it's tolerable. And it includes things like finger stiffness or pain. We saw gynecomastia in 1 out of 9 guys in TRIIM and roughly 2 out of 18 guys in TRIIM-X of the same proportion. It's not a problem in either case. We saw muscle soreness in 1 gentleman in TRIIM, but we haven't seen that so far per se in TRIIM-X, so that would be more like in the carpal tunnel category in TRIIM-X. 1 person in TRIIM felt anxious. We have not seen that happen. And we didn't have anybody have difficulty tolerating metformin in TRIIM, but we've had a few people in TRIIM-X have difficulty tolerating metformin. There's one woman who had difficulty with that, and that's been resolved, and had difficulties as well. But generally, it's not a problem. So in terms of more objective side effects, PSA spikes were observed in 1/3 of the men in TRIIM. And in TRIIM-X, the same proportion has been affected. In both cases, these spikes go away when you briefly pause treatment, or if you just power through it by lowering the doses a little bit. We saw the hair darkening effect in 3 out of 9 men in TRIIM. We have not seen that effect in TRIIM-X, although 1 woman's eyebrows got darker. I reported in some audiences before that I was concerned that there seemed to be a trend toward reduced hematocrit and hemoglobin, which was not noticed in TRIIM, but more recent analysis suggests that that's temporary and that actually these factors improve over time in TRIIM-X. So we do have some other things that we can report on now that are confirmatory for what we saw in TRIIM. One of them is with respect to PSA, prostate-specific antigen. This is the risk of prostate cancer. That has gone down, although we hadn't hit statistical significance, but that's because we haven't corrected the data to eliminate the PSA spikes, which are an extraneous factor. So I expect that to hit significance when we clean up the data. But even without doing that, free PSA has gone up to a very statistically significant degree. We've seen a trend for a reduction in CRP as we did in TRIIM. Again, this data needs to be cleaned up because we had several inflammatory events, including accidents and ant stings and things like that. But generally speaking, it seems confirmatory. We've also obtained confirmatory evidence in TRIIM-X that the plasma pheno age, which I've got misabbreviated in the title here, can be reduced. And we find that there are different response categories. This is the most robust response category. These people actually respond very quickly and seem to reach a plateau in their response around 6 months or so, which is not what we saw in TRIIM-X. You can see that the males and the females respond very similarly. And I put a regression line through the mean for all sexes, which looks like an exponential decay. Now, this is different, as I pointed out, from what we saw in TRIIM. In TRIIM, if you fit the epigenetic age regression by a month, you get a perfect quadratic fit, and it predicts that the epigenetic age reversal may continue to accelerate over time, but we didn't see that in this group of people. However, overall, we are seeing trends that are consistent with this. There's a quadratic behavior of this for some reason. Initially, your epigenetic, or let's correct myself, the plasma pheno age tends to go up in many people, but then comes back down again, and the difference is still statistically significant at the end of the trial. But I don't want you to get hung up too much on the exact numbers for plasma pheno age, because we still need to do a detailed comparison between plasma pheno age and the epigenetic aging clocks. And these just point out some discrepancies that can take place between the two. On the left, you see that in general, the change in epigenetic aging acceleration with treatment in TRIIM lines up pretty well with the changes that you see in plasma pheno age. See some significant discrepancies of up to 10 years or so for specific individuals. And these are 3 individuals on the right in TRIIM who showed a reduction or a mild increase, transitory increase in grim age minus age, but showed the plasma pheno age or a magnified negative in terms of the plasma pheno age. So don't take the plasma pheno age results too seriously yet, but they are broadly consistent with what we saw in TRIIM. We have not seen so far in TRIIM an improvement in kidney function, unfortunately. We'll have a deeper look at that, and remember the trial is not completed yet. And we previously reported that there might be an improvement in blood urea nitrogen, suggesting an anabolic effect, but we're not seeing that now. We are continuing to see a reduction in carbon dioxide levels in our volunteers, which is really interesting. It may it may show an improvement either in pulmonary function or in metabolism as people undergo the treatment. So that's very interesting. We're also seeing these other new effects of significant healthy weight loss, particularly in women, improved strength in men and women, improved endurance in men, and improved athletic performance in both men and women. We'll have some more things to say about that in a second. And in women in particular, there seems to be a trend for them to have a more youthful appearance after spending some time in the trial. And I just don't have before and after pictures to show you right now, but we hope to have that in a future presentation, because they're really quite striking. They were very impressive. So here's some subjective results, and as Brian would point out, these are anecdotes, but if you pile up enough anecdotes, eventually it turns into this. So it's interesting to note some of these things that people have told us. So this 61-year-old woman says, people ask me why I look so young. I lost 5 pounds without any effort. Before the trial, I couldn't lose weight. I can also read without glasses now. And she had many other things to say as well. Those are some of the highlights. 68-year-old woman, I lost 16 pounds during the trial. 65-year-old man, I gained weight, but it isn't fat, presumably it's muscle, lean body mass, which normally doesn't happen with just growth hormone. 69-year-old woman, I can feel myself getting younger. And a 70-year-old man, I feel great. I feel more energetic. My masseuse says I'm leaner than I've been in 10 years. Here's a report from a 70-year-old woman. I am 10 pounds lighter. I just got back from skiing at Mammoth. I was beginning to think about giving up on skiing because it's too much of a pain, but I felt the tears of joy up the way, up the ski lift on my first run. I was exhilarated, feeling fantastic. I felt energized, strong, agile, and like I was 14 years younger. And actually, plasma pheno age-wise, she kind of was. And she says I had moved into medium ski pants and now I was comfortable back in my small ski pants. 64-year-old man, my resistance weights are up across the board by 10%, whereas I had plateaued before that. I swim 1 mile 3 days a week, and I'm now faster, and I pass the youngsters who used to pass me. I've been feeling great. Volunteer's doctor saw the volunteer and said he wanted growth hormone too, just based on how she looked. This is an extraordinary guy. He got into the race at the age of 99 or so, and so he's mostly 81 in his experience in TRIIM. He's been running 5Ks, and he won the first prize medal. The lady questioned his age because she thought he must be younger than that, and he was never an athlete before. He reported to us on achieving his best 5K time in his second race and beating the youngsters with no pain, and noted that at his age, half the competition is dead, so he's pretty happy. And then he wrote to us about a third race and then a fourth race, and he just keeps getting better and better. And this is his best time again in April, and he didn't even work that hard. Now, as you have to worry about the placebo effect, as Brian Kennedy was talking about, but we do have some objective results that we can point to. So here's some objective leg strength results for one 70-year-old man and one 61-year-old woman. Of course, the man was stronger at baseline, but the woman actually increased more in terms of her percentage increase. And one of these metrics ended up looking stronger than the man, which is pretty darned impressive. Here's another example in which we're measuring VO2 max and lactate threshold. And there's improvements in both of these parameters for both the man and the woman. The man did better in terms of his VO2 max percentage change, but the woman is still doing quite well. So these are objective measures. We don't have a lot of these just because these are optional tests, but they're very encouraging. So just to summarize where we are right now, I would say that the early results from TRIIM-X are broadly consistent with results from TRIIM, and most data, unfortunately, still remain uncollected. So these are early days, and we have a lot of data processing to do. We're just getting some of these results as I speak to you today, so much additional analysis is needed. But the other dimension to this is that, or these preliminary evidence indicates that in addition to what we measured before, TRIIM-X Thymus regeneration protocol can induce positive functional improvements that may have significance for general health and quality and enjoyment of life. So thanks for your attention. And if anyone wants to contact me or our CEO for additional information, we're certainly available through LEAF and through other means. And we have a website, www.intervenemune.com, that you can consult as well. So thanks for your attention.